Midostaurin is an example of a first-generation type 1 FLT3 inhibitor. The first-generation FLT3 inhibitors are generally less specific for FLT3 and have multiple targets. In fact, midostaurin is not only a tyrosine kinase inhibitor, but also inhibits a number of serine threonine protein kinases. It is a type 1 inhibitor, meaning it binds to the ATP binding site and will inhibit wild-type FLT3, but also FLT3 with an ITD mutation or a tyrosine kinase domain mutation. The RATIFY trial was an international phase 3 study evaluating the benefit of midostaurin versus a placebo, in addition to induction chemotherapy, standard high-dose cytarabine consolidation, and followed by maintenance for 1 year with either midostaurin or placebo. Over 700 patients were treated in the study. The primary endpoint of the study was overall survival. The overall survival of patients treated with midostaurin was superior to those that received placebo. The median survivals were dramatically different, 75 months with midostaurin versus about 25 months with placebo, but this dramatic difference was really due to the fact that the survival curves by Kaplan-Meier analysis really plateaued around 50%. If you look at the 4-year survival, there was a 23% reduction in the risk of death. The survival at 4 years with midostaurin was 54%, and it was 47% with placebo. The importance of this study to the field is that this is the first time that the addition of any agent to standard chemotherapy in the past 40 years has resulted in a benefit in terms of survival for patients with AML, and most dramatic because this is a group of patients who often have a very poor survival, especially those with the FLT3 internal tandem duplication. What isn't clear from the results of the midostaurin or RATIFY trial is how was this benefit achieved in patients with a FLT3 mutation? Of course, they all had to have a FLT3 ITD or TKD mutation. However, we know that the median number of mutations in an AML sample is about 4, so other mutations may be present. We don't have the analysis of the majority of those other mutations. There was a presentation looking at the interaction of nucleophosmin and FLT3 in this study, again showing that patients with mutated nucleophosmin, especially with the FLT3 TKD mutation, do very well. One thing that has led us to question whether the benefit of the midostaurin was truly only due to inhibition of FLT3 or maybe some of the other targets that are inhibited by midostaurin is the fact that when we look at the hazard ratio for survival in subsets of patients based on high allelic burden or low allelic burden FLT3 ITD or even the FLT3 TKD, there was a benefit in all groups. In fact, the most dramatic benefit was in patients with a FLT3 TKD mutation, leading some to wonder if the benefit of midostaurin may be due to not only inhibition of FLT3, but some of these other targets that might be important in the pathogenesis of AML. Whether we need a specific inhibitor for the ITD or not is unclear, and it really has to do, the best FLT3 inhibitor will be judged by activity in the patient population, toxicity profiles, and the such.
The other important thing that was seen with the RATIFY study is that the midostaurin was not used continuously. It was used between days 8 through 21. And this is important to note because there were phase 2 studies where the midostaurin was used from day 1 through 28 of the entire cycle, and there was a lot of GI toxicity. So to avoid the overlapping chemo and midostaurin, the midostaurin was started on day 8, which was right after the completion of the 3+7, which goes on for 7 days. So what we are now seeing is that most community physicians are able to get the results of their FLT3 testing in between 6 to 7 days, and they are able to add the midostaurin on day 8 or 9. But what we would recommend at MD Anderson and most other centers is even if it takes you a little bit longer to get the testing results, we still think it's more important to add the midostaurin rather than worry about the day 8. So I get a lot of calls from physicians where they say, you know, I got the result on day 10 or 11, what should I do? And I recommend to still do the 14 days of the midostaurin. Instead of doing 8 through 21, you could do day 11 through 25 or so on and so forth. But just because it's delayed, I would not avoid using the midostaurin because I think it still has a lot of benefit.